Hi, welcome back to your prescription for medication education. My name is Enmi and I'm a pharmacist. And if you enjoy learning about medications, then this is the right channel for you. Today I'll be talking about clonidine, methyldopa, and guanfacine. So let's just go ahead and get started. Okay, just like last time, I'll go ahead and start off the video with 5 questions. These questions are just for some fun. At the end, I'll go ahead and provide the answers. Question number 1. A patient taking guanfacine extended release for ADHD is instructed to avoid taking it with a high-fat meal. What is the primary reason for this recommendation? Is it A, decreased drug absorption leading to subtherapeutic levels, B, increased drug exposure due to enhanced absorption, C, delayed gastric emptying reducing peak concentration, or D, increased first-pass metabolism via CYP3A4? Question 2. A patient taking clonidine and a beta blocker plans to discontinue both medications. Which of the following is the best recommendation? A, stop clonidine first, then the beta blocker. B, stop both medications at the same time. C, stop the beta blocker first, then taper clonidine. Or D, taper clonidine first, then stop the beta blocker. Question number 3. A patient on methyldopa develops anemia. The labs show increased lactate dehydrogenase, an increase in direct bilirubin, decreased haptoglobin, positive direct Coombs test. Which of the following best describes the mechanism of this condition? Is it A, drug-dependent antibody-mediated hemolysis, B, complement-mediated intravascular hemolysis only in the presence of a drug, C, drug-independent autoantibody formation against red blood cells, or D, oxidative stress-induced hemolysis? Question number 4. A patient is taking extended-release clonidine for ADHD. The provider wants to discontinue therapy. Which of the following is the most appropriate taper strategy? A, stop immediately due to long half-life. B, reduce dose by 0.1 milligrams every 1 to 2 days. C, reduce total daily dose by less than 0.1 milligrams every 3 to 7 days. Or D, switch to immediate release clonidine and stop after 2 days. And the last question, question number 5. A pregnant patient is taking methyldopa and ferrous sulfate. Her blood pressure becomes increasingly difficult to control. Which of the following best explains this interaction? Is it A, iron increases hepatic metabolism of methyldopa, B, iron forms a complex that reduces methyldopa absorption, C, methyldopa increases iron excretion, or D, iron induces CYP-mediated metabolism of methyldopa? Before reviewing the mechanism of action of centrally acting alpha agonists, let's do a quick and oversimplified refresher on the neuroanatomy involved in blood pressure reduction. The nucleus tractus solitarius serves as the primary integration center for cardiovascular reflexes. It receives input from baroreceptors located in the carotid sinus and the aortic arch. Increased firing of the baroreceptors activates the nucleus tractus solitarius, which will then send excitatory signals to the caudal-ventral lateral medulla, which will then send inhibitory GABAergic signals to the rostral-ventral lateral medulla. The rostral-ventral lateral medulla is considered the vasomotor center and is the primary source of sympathetic drive to the cardiovascular system. So if the rostral-ventral lateral medulla fires less, then sympathetic activity decreases, and therefore heart rate, vascular tone, and blood pressure decrease. Centrally acting alpha agonists reduce blood pressure by stimulating alpha-2 adrenergic receptors in the brainstem's cardiovascular centers. In the nucleus tractus solitarius, alpha-2 activation increases inhibitory input to the rostral-ventral lateral medulla, just like I explained in my last slide, which decreases sympathetic outflow from the spinal cord. This reduces norepinephrine release from postganglionic sympathetic fibers onto blood vessels, resulting in less vasoconstriction. Alpha-2 activation also increases vagoactivity to the heart, helping lower heart rate. If used as monotherapy, centrally acting alpha-2 agonists are typically less effective at lowering blood pressure than many first-line antihypertensive agents. Methyldopa has been shown to reduce blood pressure by approximately 13 millimeters for systolic readings and 8 millimeters for diastolic readings versus placebo. Clonidine tends to produce similar or slightly greater reductions. Common adverse effects include dry mouth, dizziness, drowsiness, and constipation. Contraindications to the use of clonidine include hypersensitivity to the drug. For methyl-dopa, it includes active hepatic disease or concurrent use of MAOIs. Warnings include cardiovascular disease, cerebrovascular disease, edema, and hematologic effects. The FDA indications include hypertension and ADHD. Methyl-dopa has been around since the 1960s. It's available in 250 and 500 milligram tablets. Its initial dosing for hypertension is 250 milligrams by mouth either 2 or 3 times a day. Some sources state it may decrease levels of B12 and folate with higher doses. As renal function declines, the dosing regimen is extended. It is contraindicated for patients with active hepatic disease. In terms of drug interactions, it also lists monoamine oxidase inhibitors and oral iron as an additional interacting drugs. As a side note, patients on methyl-dopa may develop edema with long-term use, which may require the use of a diuretic. Clonidine was approved in the 1970s and is available in multiple formulations. Oral products include immediate-release tablets and extended-release tablets. These formulations are not interchangeable on a milligram-for-milligram basis because of pharmacokinetic differences. Clonidine tablets are labeled as clonidine hydrochloride, whereas the transdermal patches are labeled as clonidine base. 0.1 milligrams of clonidine hydrochloride is approximately equivalent to 0.087 milligrams of clonidine base. An additional formulation includes a preservative-free epidural solution. For hypertension, the usual starting dose of immediate-release clonidine is 0.1 milligrams orally twice daily. The transdermal patch is a membrane-controlled system and should not be cut, and should be removed before MRI because it may contain metals such as aluminum. Labeling also recommends removal before defibrillation or cardioversion. Clonidine's half-life is typically 12 to 16 hours but may increase to about 41 hours in severe renal impairment, so it should be titrated carefully. As a side note, clonidine lowers heart rate to a greater extent than methyl-dopa. Guanfacine was approved in the 1980s, and it does have a brand name for its extended-release formulation named Intuniv. It's available in 1, 2, 3, and 4 milligram tablets, but the 3 and 4 milligram tablets are extended release only. For the treatment of hypertension, its immediate release formulation is FDA approved, but its extended release formulation is indicated for the treatment of ADHD. For hypertension, the initial starting dose is 0.5 milligrams to 1 milligram by mouth at bedtime in order to reduce somnolence. Many of the drug interactions involve medications that cause CNS depression. Others include beta blockers, tizanidine, and medications that inhibit or induce CYP3A4. Let's look at some of the common side effects such as sedation, dry mouth, and constipation. Drowsiness and sedation occur because of alpha-2A receptor activation in the locus coeruleus, the brain's main noradrenergic arousal center. This creates a negative feedback mechanism that reduces central sympathetic outflow, decreasing neuronal firing in this region with minimal suppression of the respiratory drive. This leads to sedation that resembles natural sleep by reducing the arousal signaling. Dry mouth occurs in about 40% of patients who take clonidine. Dry mouth results from decreased central sympathetic outflow and direct peripheral alpha-2 receptor-mediated inhibition of salivary gland secretion. Constipation occurs in about 10% of patients because alpha-2 receptor activation reduces gastrointestinal secretion and motility. Dizziness occurs in part due to bradycardia and hypotension, which can lead to lightheadedness or presyncope. These side effects are generally dose-related and tend to diminish with continued therapy as tolerance develops. Methyl-dopa is contraindicated in active hepatic disease such as hepatitis or cirrhosis because the drug itself is associated with hepatotoxicity. The underlying mechanism appears to be immune-mediated rather than dose-dependent toxicity. Methyl-dopa hepatitis resembles viral hepatitis in both presentation and histology. Patients will typically present with fever within 1 to 4 weeks after starting therapy, with jaundice appearing within 3 months. So it's vital that periodic liver function tests are conducted, especially during the first 6 to 12 weeks of therapy, or if unexplained fevers occur. Because of its hypersensitivity mechanism, if hepatotoxicity occurs, methyl-dopa should be stopped and should not be reinstituted. Methyl-dopa is associated with several significant hematological effects. A positive direct Coombs test occurs in about 10 to 20% of patients with prolonged therapy. The FDA recommends performing a direct Coombs test before therapy and at 6 to 12 months after starting treatment, as this is when Coombs positivity typically develops. The incidence of Coombs positivity is lowest at daily dosages of 1 gram or less. A quick refresher on what a Coombs test does. A direct Coombs test checks whether antibodies or complement are already bound to the patient's red blood cells in vivo. Indirect Coombs test checks whether free antibodies are present in the patient's serum that could bind to red blood cells in vitro. A positive Coombs test may not revert to normal until weeks to months after methyl-dopa is stopped. The FDA recommends obtaining a baseline blood count before treatment and performing periodic blood counts during therapy to detect hemolytic anemia. It's important to understand that a positive Coombs test does not automatically mean that the patient has hemolytic anemia, and a positive Coombs test is not a contraindication to continue therapy. However, a positive Coombs test means that further evaluation should occur to determine if hemolytic anemia exists. We can check the patient's reticulocyte count, lactate dehydrogenase, haptoglobin, or indirect bilirubin. A positive direct Coombs test alone will not interfere with blood typing or cross-matching. However, if an indirect Coombs test is also positive, problems may arise in the major cross-match. If hemolytic anemia develops in the setting of a positive Coombs test, methyl-dopa should be discontinued and not be reinstituted because methyl-dopa induces a drug-independent form of hemolytic anemia, where the autoimmune response persists even in the absence of the drug, unlike drug-dependent mechanism. The good news is that most patients with a positive Coombs test never actually develop hemolysis. I tried to find an incidence rate, but couldn't find one. Suddenly stopping clonidine has resulted in symptoms such as nervousness, agitation, headache, tremors, and rapid rises in blood pressure. Rare instances have resulted in cerebrovascular accidents and death. The withdrawal system occurs because of the sudden loss of central sympathetic inhibition, resulting in a catecholamine surge, increasing plasma norepinephrine levels, causing rebound hypertension and sympathetic hyperactivity symptoms. Immediate release clonidine labeling says to discontinue therapy by reducing the dose over 2 to 4 days to avoid withdrawal symptoms. Let's look at some of the special situations. For patients on beta blockers, the beta blockers should be stopped several days prior to gradually stopping clonidine. Why stop the beta blocker first? If a patient is still taking a beta blocker, the beta-2 vasodilation is blocked. So during the catecholamine surge that can occur, the alpha vasoconstriction is left unopposed, which can make the rebound hypertension worse. So stopping the beta blocker first allows beta-2 mediated vasodilation, which can help blunt the rebound catecholamine surge during clonidine taper. For patients on extended release clonidine formulations for ADHD, it's recommended that the tapering occur at an even slower rate. For example, if discontinuing the generic extended release oral tablet of Cat-Bay, then the total daily dose should be tapered in decrements of no more than 0.1 milligrams every 3 to 7 days, meaning it could take 2 to 4 weeks to fully taper depending on the patient's current total daily dose. What about transitioning from one alpha-2 agonist to another, such as guanfacine? Unfortunately, a prompt via open evidence found no standardized guideline-based protocols for switching from one to the other. It did, however, recommend a cross-taper approach where guanfacine is introduced for 1 week before slowly tapering extended-release clonidine over 2 to 4 weeks. It suggested this approach rather than a sequential approach where clonidine is tapered fully before starting guanfacine to maintain continuous receptor occupancy throughout the transition, decreasing the risk for withdrawal. Again, I want to emphasize that this is not a formal recommendation, and I could not find a standardized published protocol. Guanfacine has some food interactions to take into account. The extended release formulation should not be taken with a high-fat meal due to increased drug exposure. A high-fat meal for pharmacokinetic food-drug interactions is defined by the FDA as a meal with at least 800 to 1,000 calories, of which 50 to 60% of these calories is derived from fat. Basically, half of the calories coming from fat. Patients should also be advised to avoid grapefruit if possible due to CYP3A4 inhibition. The FDA recommends reducing guanfacine to 50% of the target dose when co-administered with strong or moderate CYP3A4 inhibitors. Grapefruit juice is considered a moderate CYP3A4 inhibitor at typical consumption levels, which is 200 milliliters or more, or one whole fruit. The timing of grapefruit juice consumption is important because grapefruit causes irreversible inhibition of intestinal CYP3A4, meaning the enzyme must be regenerated rather than simply waiting for the inhibitor to clear. This creates a prolonged window of interaction risk. A pharmacokinetic study using midazolam, which is a CYP3A4 substrate, established a recovery timeline after a single 300 milliliter grapefruit juice exposure. The recovery half-life was estimated at approximately 23 hours, meaning it takes roughly 3 days or 72 hours for intestinal CYP3A4 activity to fully recover after a single grapefruit juice exposure. The American Heart Association scientific statement notes that a 10-hour interval between grapefruit juice and drug administration has been shown to reduce the impact of potential interactions, but recommends avoidance rather than timing strategies. Major drug interactions with alpha-2 agonists include medications with CNS depressant effects, such as alcohol or benzodiazepines. Tizanidine is an alpha-2 adrenergic agonist that can produce hypotension as a pharmacological effect. So when combined with other alpha-2 agonists, the hypotensive effects are additive, increasing the risk for hypotension. Methyl-dopa has a unique interaction with monoamine oxidase inhibitors due to the risk for hypertensive crisis. Methyl-dopa is metabolized to alpha-methylnorepinephrine, which is considered a false neurotransmitter. Alpha-methylnorepinephrine is considered the primary mediator of methyl-dopa's antihypertensive effect. Alpha-methylnorepinephrine is a substrate for monoamine oxidase. When MAO is inhibited, alpha-methylnorepinephrine accumulates in peripheral sympathetic nerve terminals. The FDA label lists this as an absolute contraindication. Co-administration of methyl-dopa with either ferrous sulfate or ferrous gluconate is not recommended because several studies demonstrate a decrease in the bioavailability of methyl-dopa when it is ingested with iron preparations. A randomized crossover trial in 12 normal subjects found that when ferrous sulfate at 325 milligrams was taken with 500 milligrams of methyl-dopa, the percentage of methyl-dopa absorbed decreased from 29.1% to 7.88%, which is a reduction of approximately 73%. This interaction is particularly relevant in pregnancy, where methyl-dopa is sometimes used to treat hypertension, and iron supplementation is frequently prescribed. If both are necessary, separate each other from one another as much as possible. So the answers to the questions from earlier are 1 Bravo, 2 Charlie, 3 Charlie, 4 Charlie, and 5 Bravo. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing. It would mean a lot to me. Thank you and have a great day.